and also try to harmonize systems so that instead of building new systems, we're adapting or adopting existing systems. Yeah, I'm going to pause there.
Okay, that's great. Thank you. Secondly, I'd like to ask our speakers how they think we can implement digital health technologies effectively and ensure accessibility to everyone. So Ms. Taylor, since your work focuses primarily on providing this accessibility in low resource settings, maybe you could start us off?
Yeah, absolutely. So we often say that, in fact, designing and developing the tech solutions is almost the easy part. The hard part actually is implementing those solutions successfully, and particularly implementing them in a sustainable way. So that's really a key focus, is sustainability. There have been far too many pilots of projects, far too many projects that fail, and we work actually very hard to try and ensure some sustainability. So that relies on a couple of factors. So one of which is a very strong implementation process. I think in the past there's been very much a focus on a sort of a drop and go approach, where you get specialized consultants, they come in, they do some training, they provide the system, and within a very short time they're gone, and it's simply not sustainable for countries to be able to maintain those systems over the long term. So we try and invest in a lot of change management and training and capacity building right up front. So from the time that we get involved to, from involving as many of the end users and key stakeholders in that design process through to developing the solution, right up to the time when you go live, and then for a period afterwards. And some of that process can be quite intensive, but we found that by investing in that implementation process up front, you really reap the rewards later on. And we've had some key successes in terms of really being able to hand over our systems for country organizations to be able to run and manage those themselves.
Right. And Professor Malliaras, do you have anything to say about how we can implement digital health technologies effectively?
Well, was really interesting to hear the comments of Linda's comments just a moment ago. Very illuminating. As an academic, as academics, we find ourselves much earlier in this process. And sustainability is, quite frankly, not something that we do very well. We like to come up with a new scheme, with a new technology, and try to launch it, to spin it out. And then we move on to the next new technology. That's the idea of what an academic should do. When I say try to launch it, a success would be if you were to get industry to adopt it and then try to take it to the field, or if a startup is launched and they take this and try to manufacture it, bring it to the clinic. Again, as academics, there is the question of interest, keeping your interest focused on the technology for a long time. This is something that doesn't happen very often. Academics like to jump from one technology to the next one, to the next one. And the second is in terms of mission and resources. It's not the mission of the university to commercialize the technology, right? Once it's generated and some proof of principle is obtained, best case scenario is that it gets adopted by industry who tries to implement it the field. So I often wonder, and again, I found Linda's answer Linda's take on this question very illuminating. I often wonder if there is a role for academics downstream this process. And currently, I would say the vast majority of academics would stop when industry adopts the technology. Does that?
Yeah.
Makes sense?
Yeah, thank you. And so my last question from me would be, are there any safety and ethical concerns that we need to consider when using health technologies? And Professor Malliaras, do you face any of these concerns in your research with neurological implantable devices?
Many, 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 many. And the key message that I want to propagate is that these technologies generate a host of issues that have to be tackled together with all the stakeholders. Stakeholders being not only the engineering team that develops the technology, not only the clinicians who are adopting this technology and trying to use it on patients, not only industry who is commercializing the new technology, but also regulatory agencies, authorities, patient groups, the whole continuum of stakeholders, from the people who work in the lab all the way to the patients who will benefit from that invention. Particular reference to bioelectronics is something that I want to make. When you design devices that are implanted on the brain, there are special issues that go above and beyond what a typical medical technology would face. And this is because you're acting on the organ that generates the sense of self. And there are talking to patients who had implants removed or new implants put in. It's very clear that there are issues of agency. There was a quote by a patient who had an implant removed because the company that manufactured that implant went bankrupt and could no longer support it. And the patient said that they felt they lost part of themselves. There are questions of privacy. We designed some devices that would go on the speech part of the cortex, the part of the cortex that generates speech, for people with locked-in syndrome who cannot vocalize. And the idea is that you read their intention to vocalize, and you use a computer to synthesize speech. Obviously, we don't want every thought that comes to our mind being vocalized. So how do you address this issue of privacy, keeping some thoughts private while others get them to vocalize? So it's a very interesting question. And again, the take-home message that I want to propagate is that it has to be tackled not only by the engineers who develop the technology, but by the continuum of stakeholders, society as a whole.
Right. Yeah, thank you. And Ms. Taylor, do you have any insights into this question?
Yeah, just to reiterate, very much around the protection of personal data is a very key consideration, one of our most important priorities. And it's obviously something that we consider very much in the design of our digital solutions in terms of, access control and authentication and that sort of thing. But there's also a fair bit to be considered just in terms of the training and change management. We often find that people are still the weakest link in the system. So, again, we have staff who are overburdened, who are busy, who are trying to remember 101 passwords. So they share passwords, or they write it down on pieces of paper. Or sometimes they're just not thinking. So they're emailing Excel files around, sharing that sort of personal information, or WhatsApping colleagues with photos. So there still needs to be a lot of education and just reiterating the message about how important it is to protect people's private personal data, and particularly in certain contexts where there is still a lot of stigma around disease. You have to be particularly careful, with things like HIV, with TB, even now with COVID, that, you know, there can be very serious ramifications if this very private information is shared unwittingly.
Thank you so much. So now, dear participants, we're going to be taking some questions from Slido, and we invite you to continue submitting and upvoting these questions. But also, if you would like to directly ask your questions to the speakers, you can do the raise hand function, and we will call on you to speak. So from Slido, we have a question from Rhiannon, who says, what do you think are the largest barriers we currently face in the integration of technology with healthcare? Professor Malliaras, Ms. Taylor?
The biggest barriers, I guess, in a research setting, again, would be communication, would be communicating very clearly the clinical need to the engineers. And on the other end, communicating the current state of the art and what's possible to the clinicians. I work with, I'm an engineer in training, and I work with clinicians for a long time. And the yield of coming up with a project worth pursuing is very low. Typically, for every 100 ideas that I come with, maybe 1 or 2 excite the clinicians. And likewise, when a clinician comes to me with an idea, oh, I want a device that does that, it's either not at all interesting to us as engineers because it's rudimentary, it has been done before, or it's impossible, violates the fundamental laws of physics. So it's just finding the one idea that excites both sides of the fence is the most important thing for making for moving things forward. And it just takes time, and it requires having a very good communication between the engineering and the clinician teams.
Okay, and I'd say from our perspective at GEMBI, we probably try and look at it a little bit differently. So we're a team of, you know, software geeks, you know, software architects, software engineers. We love cool tech stuff. And so there is very much a tendency to come up with some great new ideas because we have some cool technologies. But we try and sort of always go back to what is the need that we're actually trying to address. So we try and really spend a lot of time understanding the context, understanding the environment, and speaking very much with the end users. So very much following the principles of user-centered design. And with that communication, and when you start opening up those conversations, then you can also start to see the potential actually for some of these technologies. And then it can actually get quite exciting. So, for example, one of our fairly recent projects involved tracking immunizations in children across for cross-border populations in Central Africa. And we used NFC card technology for that. And also fairly innovative in the sense that we built our own little solar panels that were able to charge the mobile devices, and we were able to implement a very effective solution, and the uptake on that was pretty high. And, you know, people do, you know, too many people come to us and say, you know, clinicians don't, you know, electronic medical record systems have a bad rap. Clinicians are resistant to the use of tools. But I think it's just that they're resistant to using bad tools. I think if you design and consider the environment and really try and fulfill a need, you will find that the uptake is actually there. And we've had, you know, instances of maybe nurses in their, you know, in their 70s who've not really had much interaction with mobile technology before, But when they've understood that this allows them to be able to identify and then check the immunization record of the child that they're caring for, they pick this up very rapidly. And so that's the exciting part of what we do.
Thank you. Flavia asks, what is the expected role of low-income countries in research and development of health technologies? I don't know if Ms. Taylor, do you want to start for this one?
Sorry, would you mind just repeating that again?
Oh, sure. They asked, what is the expected role of low-income countries in research and in the development of health technologies?
Well, I think it's an absolutely crucial role, because one of the advantages actually that I find to working within Africa, especially in very low resource settings, is that because there's nothing there in place already, you get this ability to leapfrog and to introduce new systems and to trial new technologies. So there's a very key role to play.
Yep, I agree with that. Brings different perspective, unique perspective, especially if the technology is to be marketed in that area. It's very important that research teams from that area are involved in the global effort to develop that technology. Otherwise, it's there's developing technology out of context is the recipe for failure. You develop something that just will not work in the field.
Thank you again. Another question we have is from Ziazi, who asks, well, she says there are many innovations coming up with many new digital health products being released. So she would like to ask, how do you evaluate digital health products?
Would you like me to kick off first?
Yep, sure.
Okay. Yeah, so actually it's something that we do a fair bit, actually, is evaluating digital health products that other people have developed. Those are largely the ones that are developed as part of open source communities. So, the notion of developing these global goods supported by communities. And when we do evaluate them, we look at things like, good development practices in terms of, how well the code is written, how security and privacy are considered, how well it meets the statutory and regulatory side of things. But a very key thing is, again, the sustainability of a particular solution. And that, how well it is supported. Is there a lot of supporting documentation? Are there training materials? And what about the actual maintenance and support of these solutions going forward? This is a particular issue with quite a lot of the open source tools that have been developed. Is, again, it's having that long-term sustainable funding to actually maintain them over the long term. And there's some very good products out there. But I think one of the issues historically has been everything is very project focused. So you have funding for a year or 3 years or 5 years, but there's no long-term plan. And they also tend to be, the projects tend to be very siloed in terms of looking at solutions for a particular disease area, for example. Whereas I do think that is changing, and you're starting to see that across the type of projects that are being funded, where we're starting to look at solutions that cater to the whole person as opposed to a particular disease. And we're looking to develop solutions that can be reused and adapted by multiple organizations across multiple countries.
Professor Malliaras, do you have anything to add on? Or
I think that was answered perfectly well. I cannot add anything. In academia, we're not into that game of evaluating digital technologies, other than looking at when you get a paper to review or a proposal to review, you try to evaluate it by using a very different criteria than the ones in the field.
Right. Our next question comes from Robin, who is asking how we can guarantee that the health data collected via technology remains confidential but becomes accessible to medical professionals.
Yeah, this is Linda, you want to go first, or should I give my take?
Yeah, feel free to, you go first.
Yeah, so in general, privacy, who owns the data is a big question. Data has commercial value, and there is, if you can monetize that and can use it to promote the generation of new technologies, that can be a good thing. On the other hand, you have to assure privacy of the data when needed. There is the overarching European regulation, the General Data Protection, that kicked in. Let me try to remind myself, when did it kick in? I think it became a law in May 2018. This is called the GDPR, General Data Protection Regulation, and it provides an overarching framework for how data is to be handled. I think that's, I don't think I can add anything more at this point. Maybe Linda, you should pitch in, and then I can see if anything else comes to mind.
Absolutely. So you're absolutely right. In South Africa, we have something called POPI, the Protection of Personal Information Act, which has been promulgated and kicks in actually in January 2021. So everyone is rushing around to meet those requirements. But so the legal framework is largely in place in a lot of these places. And of course, from a systems point of view, there's a lot that you can do around protection of data in terms of role-based access, in terms of having very strong auditing capabilities, and systems that can provide alerts if someone is trying to access unauthorized data. So there are a number of things that you can do. Also, just in terms of where we work, the space we work is largely with ministries of health. So it does tend to be data that is owned, it's public health data owned by the ministries. One of the other areas that we need to be very aware of is that a lot of data cannot be hosted in the cloud. So that's a regulatory requirement in a lot of places. So if the server is actually sitting within the boundaries of the country, then it may be possible. But we do find, because of that regulation, that and ironically, sometimes the data is actually less secure because it's sitting in data centers which don't really have the requisite infrastructure. They don't really have the levels of staffing and that they really need to be able to secure it. So there is this tension between wanting to retain ownership of a country's data versus, the need to really secure that.
Professor Malliaras, did you say you wanted to add anything else onto that just now? Or?
Nothing else came to mind. Yeah, I think it is a very important question. I'm not exactly sure to what extent it is being addressed. I do hope that this new regulation will make things at least more traceable.
We also have someone in the one of our participants who has raised their hand. So if Mark, you want to come and ask your question, you're welcome to do so now.
Thank you, Sammy. So yeah, I just want to add a little part, no, add, but more I'd ask about. So you talked about data regulation, and I was just wondering what the situation is in, say, Africa and less developed country about how much data sharing is actually going on between them, and if there isn't that many, well, if there isn't that much, what do you think they could do in the future to further like improve these kind of health data sharing?
Certainly, to my knowledge, there is no data sharing currently in place. Certainly, no official data sharing. Having said that, there are many initiatives actually underway to try and promote more data sharing. So certainly in terms of various research projects where the data is collated, it might be shared. But in terms of the operational systems that we've been involved with, there's no cross-border sharing of data currently.
We also, sorry. Is there, Professor Malliaras, did you want to add anything, or should I move on to the next question? Sorry, I accidentally cut you off.
In an academic setting, there is sharing of data in a borderless fashion. When you publish a paper, it's shared broadly, with a caveat that some of the journals will put a paywall, which excludes some universities, some countries from accessing. There is a big shift over the past few years towards open access publishing, where in a sense you pay to get your research published, but then it becomes available to everyone. There's no paywall for accessing the data. I like that model very much because it promotes open access to research data.
Thank you. And we have someone else, another participant, Constanza. If you want to ask your question, you're more than free now.
Thanks. I would like to ask a bit, what was your position based on, because then there's lots of countries that have very perceived corrupt governments. So is there any entity that is also auditing in those governments, so then to make sure that the citizens are whose data is being stored are also safe from those governments? So is there like any, because then you might have the country's legal frame, but one thing is that, and the other thing is whether the people trust or may trust those governments, and whether there's like any like international legal frame around that.
Linda, is this something that you know about?
To be honest, it's not something I really know about, but I think it's a great point, because certainly I can tell you in terms of the citizens and the patients, there is very much a feeling that they don't particularly trust governments with a lot of their data for various reasons, ranging from the potential for it to misuse it for political purposes to just the sheer inability to manage it properly. So, there are legal frameworks in each of these countries, but quite, how well those are monitored and enforced is another question.
Mm.
Okay, and another person, Bianca, you're welcome to ask your question too.
Hi, thank you for the talk. I wanted to ask, you mentioned about academics or dissemination as important to bring international communities together. How do you account for, because open access publishing has increased the uptake, particularly for certain countries, but how do you account for things like language barriers, which may be reducing the amount of uptake certain countries may be having?
Mm-hmm. Yes, language barriers are a major issue. Now, the best journals are making an effort to look past the paper written in English that is not standard, and they would provide a polishing service once the science has been vetted by the reviewers. I think that goes some way into addressing this. For whether it's a good thing or a bad thing, today English is dominating as the language of science. And in the past, if you look 50, 100 years back, there were more journals in other languages. There is lack of diversity today, in a sense, because most of the good journals today are published in English language. On the other hand, that makes it a bit easier if you have to just master one language and have it be the language of scientific communication, rather than having to know English and German and Urdu and Chinese, so that you can look at all the hundreds of journals that are out there.
Ms. Taylor, do you have anything to add?
Maybe just to say, from developing electronic digital health solutions, we probably have a similar concern in that they tend to be primarily developed in English or possibly French or Portuguese within Africa. Having said that, it's probably the only feasible solution. So although we do have some examples, say like a mobile app where some of the content is available in some of the local languages, we're trying to cater for so many different languages that it becomes just not feasible to be able to support all of those. For example, in South Africa, we have 11 official languages. So all official documentation is actually produced in those 11 languages. But in terms of the systems that we develop, they are primarily English systems.
Right. Well, if there isn't any more raised hand questions, then we'll go back to Slido for a bit. So Matthew wants to know what kind of healthcare data is most valuable to tech companies for research and development, and how can healthcare providers help? Do you have any insight on this?
I mean, for research and development, it is important for us to know what is needed, what the needs are. For example, let's say numbers such as the number of people who suffer from a particular disease is important in prioritizing different efforts. For example, we know today that more people suffer from dementia than from Parkinson's. So that, in a sense, establishes a rank. There is more need if you were to come up with a device for treating dementia than a device for treating Parkinson's. Such quantitative data are extremely important in prioritizing the development of technology. Does that make sense? Is this something that you're tries to address your question? Have I completely missed the mark?
No, I think that's helpful, and that's very insightful. Ms. Taylor, anything you want to add?
Yeah, I guess from our perspective, I mean, we respond to our clients. Basically, we ask them what sort of data is most useful to them, and how can we best provide it. So I guess in a lot of senses, it's all data, every bit of data, because increasingly, particularly in the area where we focus on, which is integrating systems, ensuring interoperability between these data systems, allows us to build up these larger and larger repositories of data, these sort of data lakes that can then be interrogated. And that's quite exciting, and it's certainly in our environment, it's relatively new to be able to use those data science techniques on big data in a way that in the commercial space they've been doing for a while, but it hasn't really been utilized as well on health data. So, you know, that's the exciting part, is to really start to pull out patterns and find sort of linkages in these very large data repositories.
Right. And we also have another question from Lorna, who asks, how can we encourage older people to take up health technologies? So for example, personal medical devices, telemedicine, etc., to improve their digital literacy.
Okay, well I can kick off with that, because I think like the example I mentioned earlier of the older lady who adopted our mobile app, is that if you really take the trouble to understand those users' needs and you actually respond to it and you provide them with information that they want, and you are able to provide it in a very usable format, so really taking those kind of UX principles very much into the design of your solution, then people will uptake it. I think we must be very beware of maybe assuming things about older people versus younger people. As long as you meet the need, people will take it up. I think maybe the only difference between sort of older users of tech and younger users is that you've got to remember, older people have to unlearn things. They've used a variety of different technologies over their lifespan, and you know, they're very used to using something, and it provides everything that they need. So you've got to give them an especially good incentive to actually change to and adopt your tool.
Yeah.
Yep, I fully agree with that. It's a great take on this question.
We also have someone from one of our participants who's raised their hand. Mika, do you want to ask your question?
Thank you for such an insightful discussion. My question is regarding cultural pushback from data sharing. Have you dealt with that when implementing new technologies? And if so, how do you deal with combating populations being wary to sharing their data, especially in a healthcare setting?
I never dealt with this issue in this exact context. One thing that is an example that might be similar in bioelectronics has to do with the development of the cochlear implant. This is a device that gets implanted in the inner ear and helps restore sense of hearing in deaf people. And when the device was first developed, it faced a lot of resistance from the deaf community for its adoption. And the whole idea was it was seen as an affront in deaf culture, in the richness of the deaf culture. It was seen as a device that will just pluck people out of that community and bring them to the world of hearing. I guess this had to be placed in balance with the advantages that this device would endow, especially in kids who were born deaf and they had a window of plasticity in their brain. And should they receive an implant at an early age, then they can function normally within quotation marks. They will develop in the same fashion as someone who has intact hearing would develop. They would be, it would be easier for them to integrate in the world, and the device could also seen as a safety device. You could hear a car coming to hit you when you cross the road. So it's a balance of the all of the arguments that I mentioned above. The discussion is still ongoing. Today, I think the balance has shifted towards the device not being seen as an affront to deaf culture, but rather as a tool that facilitates integration of deaf people in the world of hearing. At any point, it can be switched off, and also as an important safety device. There are discussions in whether a neonate should get an implant should the parents decide to against it, whether society should decide that no, the kid should have an implant regardless of what the parents say, or whether the parents should have the final say. There is some discussion that still goes on, but by and large, this is one example of, again, when you develop a technology, you have to involve every stakeholder, including the patients, including the patient advocates. I know it's not answering exactly the question that you asked, but I think there are similarities that you might find interesting.
Yeah, thanks. And maybe just to add to that, it's something you very definitely do have to be aware of, you know, being sensitive to cultural differences. One of the key areas actually we found within the last few years has been, you know, something as simple as on a form where you're entering gender, male or female. You need to be very careful of not being seen to impose your own values and your own interpretation of that on other groups of people. And so you do need to be sort of aware of these type of things. The language is another area where, again, we had that experience when we were implementing a particular system. And we were told, again, we had a field which just allowed someone to select language in which they could receive an email or an SMS notification. And the guidance we were given was that rather just keep it to the one official language, because if we can't cater for the 20, 30 odd different languages and only pick a subset of those, then it could be seen to be favoring a particular ethnic group. So you do have to be aware of all of these. Again, just comes back to understanding who you're designing for.
Great. So we're going to take 2 more questions. Queenie, do you want to go ahead and ask yours?
Yes, thank you very much. So personalized medicine is quite a popular topic nowadays, but there are also studies trying to develop a universal solution to certain diseases that is applicable to people, for example, with different genetic profiles. So they're sort of the 2 opposite ends of the spectrum. Then which way do you think will be more important, at least in the near future, and what are the roles of healthcare technologies in these aspects, especially in the post-Human Genome Project era? Thank you.
I think this is a great question. I think there is a general trend towards personalized medicine, especially for high-end products. Now, for a painkiller, it still works if you take a generic ibuprofen. But for an implanted device, there is definitely some degree of customization that goes into at least the mechanism of operation of the device. The hardware might look very similar between what's implanted in one patient and in another, might be different in size or in electrode location, but the actual electrical stimulation protocol is customized for the patient. Now, this puts a lot of burden on the physician who has to work with a patient over several sessions to try and customize the therapeutic profile of stimulation for that individual patient. But the outcome is the best for the patient. And here is a case where one solution doesn't work for everyone. It absolutely has to be customized.
Right.
Yeah, maybe just add my sort of 2 cents worth to that. So again, a slightly different perspective, but I think what we are seeing in terms of the digital solutions is the shift away from aggregated data systems that really just provide data to the central decision making to inform policy, and more towards sort of clinician-focused solutions, but ultimately actually to patient-focused solutions. So things like a mobile app, where a mother who is probably the best person to understand the current status of her child's health is able to actually retain that information sort of in the palm of her hand. So, for example, one of the things that we have worked with the South African National Department of Health on is a mobile app that digitizes the, it's called the Road to Health booklet, something that's issued to every child if they're born within South Africa, and it records, you know, birth weight and circumference, and it has your immunization record and so on. And over time, the intent of that is to build up a patient-focused record that the mother is able to carry with her on her mobile phone.
Thank you so much for answering the question. And our last question comes from Vice, who is asking if healthcare is a social, economic, and cultural issue, how can we prevent technological advances that make it even worse, that make the inequality even worse between countries?
Well, you have to vote for the right people. That's at the end of the day, that's the answer. It's extremely important that technologies are made available. Healthcare technologies is a good for everyone, and they should be made available for everyone. So I'm a big proponent of a national health service like there is in the UK, where I currently live, like there was in France, where I used to live before. If you see what happens with the COVID vaccine, some countries are going ahead and announcing that they will make it available to everyone in their health system, free of charge. I think these are the people to vote for.
Yeah, and I would back that up 100%, because I think it's a great question. I think it's a very serious and growing issue. But yeah, be very careful who you vote for. Think very carefully about who you vote for, but also make sure that you do vote.
Well, I think that concludes our panel discussion for today. So I'd really like to thank Professor Malliaras and Ms. Taylor for contributing to this discussion on health technologies. And we got through a lot of topics from data protection to healthcare sustainability, uptake in the elderly, and the roles of developing countries. So that was very, very interesting. Thank you. I'm very sorry that Dr. Ampadu couldn't make it, but perhaps if there's any questions for her, we might be able to reach her some other way. And thank you. I'm going to, Siatsi and Constance.
Yeah, thank you, Sammy, and our two amazing panelists for this very interesting discussion on healthcare technology. And thank you, participants, for asking your questions, both directly via Zoom as well as using Slido and upvoting them. So once again, thank you everyone for participating in day one of CamWHO 2020. We hope you have enjoyed today and learned a lot from the speakers as well as through discussions with your fellow delegates. So this concludes the end of day one. However, this is not the end of unofficial day one, because later on at 5:30 p.m. we have a Zumba session for you over the delegates Facebook group. Everyone is welcome to join. We have a special Zumba instructor hosting the session, so we promise it will be very, very fun. And of course, tomorrow morning, we will have an online social, which we will have the opportunity to have a brunch quiz on global health and other interesting topics. So it will be before day 2 officially starts, from 10 to 10:50. And you're welcome to bring your own brunch food and just chat with the participants, hang around, or even participate in the quiz. So thank you once again to all participants and delegates. Have a good evening, and we will see you for day 2 of CamWHO 2020. Thank you, and thank you, speakers.
Great.
Great. Thank you very much, everybody.
Thank
Have a
you
great
all.
weekend.
Thank you. Good
Bye.
evening. Thank you.
Thank you.